Welcome, everybody. My name is Scott Zieger, and I'm a professor of biostatistics in the Bloomberg School of Public Health and also director of the Johns Hopkins Individualized Health Initiative, about which I'm going to make a few brief remarks before I introduce our speaker and our formal discussant. We appreciate your being here. We know you were mandated, some of you, to do other things. The dean is here, so don't feel so badly for not having done your sex harassment training today. I'm told you can do it online, although I'm told the exam is harder if you do it online, so I'll leave you to worry about that. Let me just say a few words about Johns Hopkins Individualized Health. This is a signature initiative of Johns Hopkins University, Johns Hopkins Health System, and the Applied Physics Laboratory. And the goal is to try to be a catalyst for the development of modern data and bioscience as a way to improve care for patients in the United States and beyond. And this slide is meant to show you what's special about Johns Hopkins. And it shows the strength that we have in clinical research and public health research spanning patients to populations. It shows that there's a strong connection between that research and what we actually do in the care of patients and in the management of populations. And most importantly, it shows how this clinical directed enterprise is built on a basic science foundation. It was built that way more than 100 years ago to bring the biosciences into the practice of medicine. And now, increasingly, those biosciences are founded on modern data science. And there's a real partnership that's developed between data and bioscience. And the goal now is to strengthen ourselves at this interface and have it inform both our clinical and patient research as well as our clinical and patient care, as shown here. And many of you are experts in the learning health system as described by the IOM in its 2012 publication. And the notion is that clinical research and public health research should drive patient care and population health care. What's special about this institution is that all of that is built on this foundation of basic science. This talk is one of a series of 6 talks, 3 of which have been completed, and I want to both tell you what we've gotten done so far and also advertise what's coming. So we had an overview presented at Medical Grand Rounds. We had a wonderful session led by Nancy Cass, Todd McNutt, Dan Forb, and David Ketzelnick from Mayo about bioethical issues to be a learning health system. And then a presentation by Chris Shute, our recent Bloomberg Distinguished Professor with Health Policy and Management about data systems for a learning health system. And it gives me great pride to introduce in just a second Earl Steinberg, who will be talking about organizational models. After that, Peter Pronovost is going to talk about culture change necessary to become a learning health system. And there's a hope that we're attracting a major CEO of a academic medical center here for the final session in May. So with no further ado, let me introduce Earl P. Steinberg, MD, MPP. Earl and I met each other 30 years ago when he was a budding faculty member in the Department of Medicine here. I've had a lot of very positive experiences with him over all that time, and he's a very special thinker about healthcare in America. He is currently the CEO of a startup company, XG, and adjunct professor of health policy and management here at Johns Hopkins. He previously was executive vice president at Geisinger and senior vice president WellPoint, and started and was CEO of a company called Resolution Health, where I had the chance to work with him on a number of interesting projects, including how to grade cardiologists in the state of Massachusetts, a job that I think was well done. If you work with Earl, you usually find yourself in conflict with important people, and we've taken on some of the best just in the few collaborations I've had with him, and I know he's got some other big challenges coming up in the future. So And I'm going to introduce our discussant first before I turn this over to Earl, but it's a special privilege, Earl, for you to be here, to have you back at Johns Hopkins. And then we're fortunate to have our own Patty Brown, who's the Senior Vice President of Johns Hopkins Medicine and President of Johns Hopkins Healthcare. She was previously Assistant Attorney General for the state of Maryland, for the Department of Health and Mental Hygiene. She's earned her JD at University of Baltimore and her bachelor's at Richmond. And she is the leader of population health care at Johns Hopkins, and so it's a natural connection to have Earl speak and then Patty to lead a discussion. I want to thank all of the people who've taken time from a very busy schedule to be here, and I encourage you to participate actively. It's not very often that you get to put Earl on the spot. He gave a lecture previously and was damaged in that process. So actually, it's not true. He was damaged by a health economist here at Johns Hopkins. So with no further ado, Earl, we look forward to your remarks.
Thank you. She said this.
That's for.
Oh yeah. Well, thank you, Scott. It's a pleasure to be here. I love this place. Had 12 very stimulating and enjoyable years here, and recall working with several of the people in the audience, so I appreciate them coming. This talk was slotted as organizational models. I'm actually going to talk more broadly than organizational models, since I don't consider myself a real expert in organizational models. And what I'm going to talk about is what do we need to do to get higher value care, part of which I think relates to organizational and management models. But more than that, and given that this lecture is in a series about individualized health, I'm going to try to weave in some of the implications for individualized care, particularly since Geisinger Health System, where I still spend part of my time as Executive Vice President of Innovation, is doing a tremendous amount of work in genomics. And we are doing some work I'm going to tell you about, trying to get better value out of electronic medical records. And I think there's an interesting intersection there. So I was talking to my wife yesterday, and she asked me what I was going to be talking about, and I told her about this slide. She said, you know, who doesn't know that? You know, I think the prerequisites for higher value care in this country are pretty straightforward and shown here. And the challenge is in execution. I hope I'll stimulate, as Scott said, I often stir the pot a bit and intend and hope that I'll do that today. So it was good to see Peter Pronovost is going to be talking about culture in the next lecture. Culture trumps strategy, as they say, every day of the week. And it is critical that there be a culture that prioritizes quality, efficiency, and innovation, and a workforce that embraces that. I've been in a lot of good places. Geisinger has a phenomenal culture. It is all about quality. It is all about doing the best for patients. And they put a high premium on innovation. Leadership and incentives are very important because even with a culture that is predisposing, you have to have people who can rally the troops. The incentive part is broken in the United States, in my opinion, very badly. And I've always been a bit cynical, but the past 2 years, I've probably visited 40 or 50 healthcare systems, and it's very discouraging. I'm stunned by the mindset and performance of these places. And we need to be moving to a more value-oriented approach for delivering and paying for care. We are in the very, very early stages of that transformation. Unfortunately, still early innings, and the jury is out as to how much progress we will make. But the healthcare system today continues to primarily be paid on a fee-for-service basis. We hear a tremendous amount about value-based payment and what percent of care is paid for, but most of what's being referred to in those stats is upside-only performance and not real risk. One of the things that I've observed is that things vary markedly, market by market. So in our company, which is focused on trying to help improve performance of providers, unfortunately, there are no databases that we can go to sort of figure out who the best targets are. You really have to go into that market, understand the structure of the market, the competitors in the market, the payers in the market, and what they're doing, what the employers are doing. And many payers are doing nothing. They're making their own money, doing just fine on the old system. I was even in one place where the provider system, a very large provider system, wanted to move more towards value-based payment. There was a dominant employer who had an exclusive arrangement on an ASO basis with this particular payer, and the payer threatened the provider that if they went and talked to the employer directly, they would slash their payment rates, which basically put an end to the consideration. What's most distressing to me is that in all the places that I've been to, the providers, the leaders, are well aware of the fact that there's tremendous waste in their system and that they are doing a lot that is of no value. I believe that the sort of line of reasoning that lets them sleep at night is that they view their hospital or health system as being of vital importance to their community, and therefore making sure that that health system stays strong financially, they view as being of great importance, even though they're delivering a lot of, unnecessary care and in many instances doing harm. The most disgusting anecdote is I gave a talk at the Brookings Institution, and a leader from a very well-known healthcare system was giving a talk about all these great things they were doing to improve quality, and mentioned in his talk the fact that they had reduced elective preterm deliveries from 14% to 8%. So if you're familiar with the evidence on that, the rate should be 0. So the data are compelling on harm. And in the Q&A, somebody asked the speaker, why isn't it 0? And the guy was like a deer staring in headlights and was fumbling and saying, well, we have a lot of movie stars and they want to have their baby when they want to have their baby, and talked about the obstetricians. And then in this short list of rationales, he said, and we make a lot of money on the NICU, which is amazing. But that was said publicly, and I don't think he realized what he was saying. I don't think he was saying that they're doing them deliberately, but I think he was referring to the fact that it's hard to stop it. In my view, if providers wanted to reduce the cost of care, they absolutely could and would. They just have to have the right incentive, and right now, most providers don't know how to move from volume to value and maintain their financial strength. And I've We've worked with many systems. We have very strong data about our ability to go in and reduce utilization, increase quality, reduce cost of care, and half the CFOs go, why in the world would I want to do that? And that's really what we're up against in the real world. It's not just about value-based payment. I think what's going to happen over the next several years is there's going to be more and more pressure, even under fee-for-service, for providers to deliver care at a reduced cost. Narrow networks, if the political system doesn't sort of put the kibosh on them, I think will result in drawing providers who are higher cost and lower quality sort of into a position of getting less volume, and many of them will not survive. I believe we have too many beds in this country. I think that states will lead in this, and we can talk about that maybe later, but I think between Medicaid and the fact that the state government is usually the biggest employer in the state, I think they're in a position to move the needle the most. I worry about the feds in that I think the current experiments on ACOs and bundled payment, while I support them strongly, I do not think the current designs are financially sustainable for providers. And so I think they will need to be changed, and whether that's going to happen or not, I don't know. And finally, there's a need for multi-payer solutions. And this is very problematic in that the payers don't want to work together, but providers cannot take care of different patients differently based on who their insurer is. Every insurer's data is different, and every insurer's data is different every month. And as a result, I don't think most providers are in a position that they can deal with that heterogeneity, and there's a need, therefore, for some sort of intermediaries to normalize that data and provide consistent results. So the second thing that's needed is knowledge, and a place like Hopkins obviously works on this all the time. There's a huge body of evidence, though, that we're not complying with now. In fact, the reason I left in '94, despite loving, as I said, what I did here, was that I thought that rather than spend another 10 years writing another 100 papers about what the right thing to do is, that it was more important to try to work on development of practical tools to facilitate compliance with what we already knew to be the right thing to do. And Beth McGlynn wrote this famous article in 2003. I actually wrote the editorial that accompanied it. And in that article, she reported that more than half of the time we are not complying with what we know to be the right thing to do. There's an even greater amount, obviously, that we don't know, and that's where clinical and basic science comes in. And as Scott talked about, the need to relate the two. Now, Scott mentioned the learning healthcare system. I love Yogi Berra, and you can observe a lot by watching, and we need to do more to systematically collect data and analyze it on what's happening on the basis of what we do today. So this is a horrible slide that people where I work always yell at me about, but basically, conceptually, I think we need something like this where we are pooling lots of different types of data. No single type of data is sufficient. We need what I call rules that are evidence-based and that will enable us to analyze the characteristics of the patients and the providers and determine what each individual patient needs, which providers are the best match for them, and then to trigger physician or care manager and patient target interventions and then observe what actually happens and then use that information to feed back and refine those algorithms in a closed loop system. One of the things that I'm spending a lot of time working on, I've spent many years analyzing data and trying to feed that data back to providers. And there's value in doing this, but one of the things that I've concluded from my 4 years at Geisinger is you can produce reports and dashboards till the cows come home. It's not as powerful as integrating the results of those analyses directly into clinical workflow. That is much more effective. So I'm not going to belabor this, but the School of Medicine, School of Public Health could spend decades doing analyses to come up with better algorithms in where lots of those arrows were in the previous diagram. I know, Scott, you talked about targeting and prioritization, and tremendous amount of value would come from good work in that. I think we are better at identifying who's, quote, high risk than we are at identifying actionable opportunities to intervene. I wanted to touch, since this is all about individualized health, and Scott commented about the Hopkins environment. I don't know how many of you have ever been to Danville, Pennsylvania. It's described by some as Alabama between Philadelphia and Pittsburgh. But it's really out in the middle of nowhere, and but it's a very, very interesting environment. And there's nobody leaves who's born there. I mean, they pretty much stay. There's multiple generations of people. Geisinger was an early adopter of HIT. They implemented Epic in 1995. And we have an enterprise data warehouse into which we feed not only data from our Epic system, but claims data for the population that's cared for by Geisinger and insured by Geisinger. We do a lot of work on patient-reported data. I'll comment on that. And we are amassing a huge database of genomic data, tissue data, and EMR data. Our chief science officer is a guy named David Ledbetter, a genomics guy, and we have a relationship with Regeneron under which we are sequencing the exomes of about 1,100 patients a week. And we originally had a goal of 100,000. We've upped it to 250,000. And there's some talk about us going up to 1 million. And what is particularly attractive, or was particularly attractive about Geisinger, is our ability to consent, get patients to consent to us approaching them and other family members. So you can see that we've already consented more than 60,000 patients, and we're consenting at like an 80% rate. I mean, it's really pretty remarkable. We're involved with a number of other genomics projects that are funded either by NIH or private foundations, in part because of our ability to integrate our EMR data with the genomic data. The next area I want to talk about, and which I think Patty probably has the most to say about, are capabilities. So most providers lack the capabilities that are needed to be successful in population health management, and particularly to go at risk. They need infrastructure, a variety of types of infrastructure that I'll comment on. They need care processes and models, and they need properly trained personnel, and in most places, all are lacking. Providers need a lot of what has historically resided in health plans. I spent 3 years in a very large health plan. They had a gazillion actuaries, nurse case managers, a lot of data analytic infrastructure, but they know nothing about how to manage care from what I would describe as the inside out as opposed to the outside in. They operate a parallel healthcare management system that's primarily remote telephonic, and the providers themselves are, either oblivious to, ignore, or irritated by what goes on. At Geisinger, we have embedded our care management resources in the delivery system, and it's much, much more effective. It's expensive, but there's a demonstrable ROI. Just going to talk briefly about the fact that we use a very structured approach and advocate it for care management. And Geisinger is not actually a great science place other than what we're doing in genomics, but we are superb at workflow and reproducibility, reliability. So we have occupational, we have engineers who we embed in our rounds and study the workflows and iteratively improve the workflows. And we strive for 100% reliability in what we're doing, and we use a bunch of automation and monitoring to help facilitate that. We also monitor quality on what we call, what Don Berwick calls a bundled basis. It's an all or none basis, but if, for example, for diabetes, there are 8 quality measures, we monitor them and you only get credit if you do all 8. It is very hard. If you get it right 90% of the time and there's 8 measures, that's 0.9 to the 8th, so your 100% compliance rate is pretty low. I'm going to talk very briefly because I have a lot of ground to cover, but I want to talk about the fact that there are many components to what we try to do, and I'm going to talk very briefly about the data analytics and our approach to care management and linkage to the electronic medical records. So most health systems that I have been out to are in search of an easy fix. So they typically buy what I call bright, shiny objects. So they'll buy an enterprise data warehouse, or they'll buy some software platform, and they don't know how to use it. The data infrastructure, data analytic infrastructure, I believe is absolutely critical to success here. And we can talk more about it, but this really more than anything is meant to say that there are lots of views that are relevant to different stakeholders. So we need to be producing data that's relevant and actionable, and we think about this at the patient level, the physician or provider level, and then at the population health level. And we have scorecards, so to speak, that we produce at each of these levels. We also have integrated this into our workflow. So we extract a targeted 10% of data from our Epic system every night and analyze that targeted 10% overnight and pump the results into our electronic medical record in a lot of ways. We embed a lot of automation, and until recently, we've never been able to effectively share any of what we've spent 18 years developing with any place else because the systems are closed, not interoperable, clunky, and I personally think the fact that we gave out at the federal level billions of dollars to get people to adopt EMRs without mandating that those EMRs be interoperable, it borders on criminal, because now we have all these EMRs out there that will not talk to each other. This is an eminently solvable problem. It's actually very easy to solve if the EMR vendors were forced to solve it. So bottom line is tools and platforms are necessary but not sufficient. You need know-how and support services. Data analytics are critical, but you have to be able to recognize what the highest ROI opportunities are. You got to integrate the results into workflow, and as I said, we need payer-agnostic solutions. We use this mantra at Geisinger in terms of re-engineering care. So eliminate everything that is of no value, automate as much as possible, delegate work. We have a team-based philosophy and approach to care. We try to delegate work so that everybody on the team is operating at the top of their license. Incorporate these revised practices into tools such as our EHR and believe strongly in the importance of activating patients and their families. We have our own approach to the advanced patient-centered medical home. There are many. The data, as you probably know, on the impacts of advanced patient-centered medical home are highly variable. Just having an NCQA certified medical home guarantees nothing in terms of performance. In fact, the correlation between NCQA certification and performance is zero. We believe strongly in embedding, as I said, highly selected, highly trained, and equipped case managers in our medical home. We believe in evidence-based guidelines. We don't make up the guidelines. We use guidelines that are produced by authoritative organizations. As Mike and Scott and others know, when I was here, I spent a lot of time working on these types of guidelines. I've got the scars to show for it. But they're not put into practice reliably. And we have succeeded in getting these hardwired into our system, and we monitor compliance with every best practice element and feed that back to the individual physicians, their clinical service heads, and their bonuses depend on their compliance. This is just a chart showing you, this was for bypass surgery from a number of years ago, but we pretty much hover close to 100%. It is possible for a doc, to bypass this. It's not easy, but they can. But we focus only on those guidelines for which the evidence is compelling. So we focus on things that we believe you either always should do or never should do, sort of what we call failure board type questions. At Geisinger, we have a rapid cycle innovation initiative. We call it PRIDE, Proven Innovation Drive for Excellence. And we've got a tremendous amount of work that goes on all the time. Everything from things like enterprise pharmacy, how our ORs operate, supply chain, workforce, et cetera, et cetera. So we are trying to continually improve every aspect of our performance. Some of the things that I thought might be interesting to people here, we've developed a very interesting predictive model that works very well to predict no-shows, people who are high risk for missing their appointments. We reach out to those people selectively, and we've reduced our no-shows substantially compared to a control group. We do a lot of simulation models, and we've improved flow through our emergency room, which has been very backed up. And we use this model now to predict surgical case length and don't listen to the surgeon anymore based on what the surgeon says the anticipated duration of the surgery will be. We're better at predicting that than he or she is. We've invested a lot of money at our company in developing an online learning system for training places. So we're interested in disseminating best practices at scale, and we can't do that if we're just relying on people. So we're now working in one health system at 108 places simultaneously within that health system. We're training a lot of case managers, and we believe that good case managers are trained, not found, that they have to be trained, and you have to find the right people. Now, since I know you have implemented Epic recently, I thought I'd talk a little bit about Epic. As I told you, we were an early adopter. Most places hate their EMR. Our docs view it as a member of the team. We've invested over $200 million in our system, and we have 200 full-time programmers who do nothing but program Epic. So I call them Epic black belts, and literally if Epic has something they're not sure about, they often call Geisinger to talk to people. Now, I think EHRs in their current form are extraordinarily disappointing, inefficient, and don't live up to their promise. So data are dispersed throughout the system and not easy to find. Unfortunately, in order to get through their documentation requirements, docs often copy and paste notes, and so you get layers of veneer on veneer of just garbage verbiage. It just takes somebody longer and longer to go through, and you have to dig further and further. We did a little analysis, took in rheumatology 18 minutes for the docs to find the data that were relevant to particular patients. We are working now, we have a number of programs where we can extract the data on an automated basis, reorganize it, present it to the doc in a much more clinically and user-friendly way, and provide clinical decision support so that we can both save time and improve quality. It's much easier to program outside the EMR than it is inside the EMR. And since everything needs a viable business model, we have inadvertently found that by improving the accuracy of the problem list, which is notoriously inaccurate from both a false positive and false negative perspective, and by providing clinical decision support, we're able to increase HCC scores significantly, and based on pilot data for our 75,000 member Medicare Advantage plan, we estimate that we'll be able to increase revenue to our health plan by $40 million a year, which has gotten their attention. Next week, we are announcing a new suite of software apps that are going to operate outside the EMR but talk to the EMR. When I first got to Geisinger, I was given 6 months to look around and see what Geisinger had that was of value and potentially exportable. And what I was most impressed with was what they had done inside the EMR and what they had done in developing software apps outside the EMR. And I thought this will be a cakewalk, this is gold. Only because I had stopped practicing before there were EMRs. I was very EMR naive and didn't realize that no copy and paste and these apps that we had spent 3.5 years connecting to our instance of Epic were hardwired and would not work in their current form anywhere else. So I've been working on this since then, and fortunately, due to this recently developed Smart on Fire data standard or draft data standard funded by ONC, we have taken these apps that historically have only worked at Geisinger and now shown that we could get them to work with Cerner, we can get them to work with Athena, and we will demonstrate next week that we can get them to work with any instance of Epic. So the hook or the rate limiting step here is the EMR vendor must Smart on Fire enable their EMR. If they do that, which is not that difficult, then this can occur. And I just show these as illustrations. The homunculus on the left is from a rheumatology app and just shows you the types of things where patients respond to structured questionnaires. The doc records. It drafts an encounter note for the doc on an automated basis. This verbiage up at the top on the right is also generated on an automated basis, and the only thing the doc has to write is a little bit in that white rectangle at the bottom left. So we are planning on coming out with a suite of apps. We've got over 20 in development. And in the genomics area, I'll mention that what we're talking to our genomics group about right now is two things. One is analyzing the data in the EMR to look at the phenotype of the patient and to advise the doc when, rather than do what they would ordinarily do as in their diagnostic or therapeutic management, advise them when a particular genomic test is the right next step, and conversely, analyze the results of the genomic tests in the light of what's in the EMR. Very quickly, I got 5 minutes. In terms of organizational management models, going to talk about our system structure, team approach, management model, and clinical service line. So for those of you who aren't familiar with Geisinger, it is a truly integrated delivery system. We have a large clinical enterprise that's got 6 or 7 hospitals. We're about to acquire another one in New Jersey, many outpatient facilities, about 1,100 employed docs. We have 46 primary care sites, and we have about 500,000 life health plan. As you can see here, about a third of the people who get their insurance through the health plan receive their care from a Geisinger primary care doc, and about a little bit more than a third of the patients that we see at Geisinger are our health plan members, and we call this overlap the sweet spot. It's where we do most of our research, and sort of left pocket, right pocket issue. We got a lot of press in New York Times, 2006 for a warranty. Really was a marketing scam because it was only with our health plan lives, so we couldn't lose. If one lost, the other won, et cetera. But in any case, we value that. This is meant to talk about the fact that we employ a structure of dyad, triad management, where clinical leaders are paired with administrative leaders, and the people at Geisinger swear by it. We have 29 clinical service lines. 6 of them are hospital-based. As you can see, they vary. Some have chief medical officer, administrative officer, nursing officer, and financial officer, but they are jointly accountable for both the clinical and the financial performance. And then they have a matrix structure with, as they go down the line. This is just a list of the service lines to give you a sense of the approach. So I'm going to close just by saying at the end of the day, it's all about behavior change. As an undergrad, I majored in psychology. Little did I know at the time that that was actually the most important part of healthcare in terms of getting docs and patients to change their behavior. A lot of work to do. It's possible. And I hope that my comments about some of the prerequisites for change have been stimulating, and look forward to discussion. Thank you.
We'll give you a seat. Good afternoon, everyone. My name is Patty Brown, and as Scott suggested, I am the Senior Vice President for Population Health, Senior Counselor for Managed Care, and the President of Johns Hopkins Healthcare. And Earl, there are a lot of holes in the presentation that I give, in contrast to yours, but the theme and the structure of what you talked about is very consistent with the things that we're talking about here. So what I'd like to do to open up the discussion is I'm going to summarize what I heard Earl say. And I'll highlight those key, I'll call them the roadmap, those key tools, or those key concepts that Earl suggested in his presentation towards value, this road that we're all on. I think we all agree that the road is a good one. I think none of us agree and or understand the pace. And hence, we're trying to figure out our own pace with regard to investments as we move this forward. So, Earl, I heard you say a couple of things. The one that I think is the most truthful, and frankly, the one that a lot of us lose sleep over, is this. Most providers don't know how to move from volume to value. Apparently, Geisinger has learned to set forth the path. But I don't know that you would even say you really know, right?
We're more volume than, we're predominantly still fee-for-service.
Most providers don't know how to move from volume to value. And then Earl just suggested it's due to the fact that he's predominantly paid fee-for-service. And I would challenge that. Why does that matter? If the second thing that you said is also true, if providers wanted to reduce the cost of care, they would. If you're paid fee-for-service and your costs are less tomorrow than they were yesterday, what have you just done? You pocketed more of that fee-for-service payment. So this, and I call it excuse that the healthcare system has now held on to. Well, we're not paid that way. It's just that. We have the controls internally, which goes back to what you, I think, wanted to spend some time on, organizational structure, to organize ourselves so to incentivize the reduction of cost. We collect money either through fee-for-service and or capitation, or through risk share. But that's a revenue stream. You can still manage your costs, I think, pursuant to your commitment to value. The other thing that you said, which I found fascinating, rather than writing papers, it was more important for me to work on the tools necessary to do what we already know we need and or want to do. And that goes to, I think, the core question that so many of us here at Hopkins are asking. And I've said this to you, Scott, many times through the InHealth discussion. is it our responsibility to not just know, but demonstrate to the market impact? And writing a paper has that, we know. But could we have more impact by doing more? By doing more than just writing the paper. And that, again, is, I think, one of the core fundamental goals of InHealth, is to put into place the translational acceleration so that it's not just writing the paper. And as you said, Geisinger is superb in workflow reproducibility, I can't read my own writing, operability, and 100% reliability. And that becomes then that question of systems. And all of the things that over the last, did you say 17 years, that Geisinger has been along this path, has been focused on and investing in, from systems to data to technology to tools to, again, organizational models. So those were kind of my high-level takeaways from what I heard Earl talk about. But I'd like to throw out a couple of different categories and then ask you all to select those that you may want to have a little bit further discussion on. The first was the organizational model. The organizational model necessary to support higher value care. I remember the first presentation that I gave around population health, healthcare reform actually, named our need to review and revise our organizational model as my number one priority, and that was probably 8 years ago. We've tweaked our organizational model, we've not fully revised it in order to ensure the work gets done. Organizational models to support higher value care on the payer side. You suggested, and I agree, that this type of transformation needs to be multi-payer, if not all payer. But yet the payers are not incentivized to do that. More for-profit models are not, in my mind, the right organizational models to support the drive to value. So what do we do about that? And I think Earl's right, the fact that the states and governments are carrying so much of the financial risk of healthcare, they are the parties that have the opportunity to change, because their incentives are not similar to the for-profit insurers. So organizational models on both sides. This need for continuous learning based on accumulated experience. Stephanie, he has a data warehouse. But our lawyers, who I am one of them, are very concerned about integrating data for the health plan into the Epic warehouse for HIPAA reasons. So a lot of opportunity, but we're moving in that direction. But that's this idea of collecting, an opportunity to collect data, not just from the payer, from the delivery system, but then as you stated, the genomic data opportunities, et cetera. Integrated care management. We've been doing this for years, but yet it's still the health plan care manager in that site. We think we are one, but we're not. Again, an organizational model problem. We've not fully thought of ourselves as a system here at Hopkins. Clinical protocols. It's a main priority in the strategic plan. Geisinger has not only defined clinical protocols, they created system capabilities to incorporate clinical protocols into the workflow. We have clinical protocols up the wazoo, but yet we've not made that extra step of really investing in moving those protocols into our business process. So another major priority. We have this sweet spot here as well. It's exactly the same as Geisinger's. 30% of the health plan patient population receives its care at Hopkins Medicine. We're a little bit smaller on the health plan side than Geisinger, but we have all the same incentives in place. We are committed to clinical service lines. It's part of John Lewin's work as in his new role as Senior Vice President of Integrated Care Delivery. Again, how do we prioritize that work, or do we do one clinical service line a decade? How do we accelerate it? And then Earl said at the end of the day, it's about behavior change, provider as well as member, patient. So those are the broad categories, and I guess I'd throw it out to say, yes, are they? And two, how do you, perhaps Earl, you can tell me the conversation 17 years ago. How do you prioritize those categories? Do you prioritize them? Do you say it all has to be done? how do you look at it organizationally to get this engine in gear so that at the end of the day, you have a learning healthcare system that you can then more than just write about, but then take out to the world. So I'd like to open up for discussion on any of those categories and any interest, but the question really is, where do we, not really do we start, but where do we prioritize our investments and deploy our resources?
Your chance.
And you're going to help us out too.
Yeah.
So, Earl, what percent of patients fall into quote-unquote guidelines, and how do you deal with the culture like we have here, where we don't follow guidelines, we create them?
It seems to me worse if you create them and don't follow them.
I am, how do you do with that culture?
Well, I don't know the answer to the percent of patients, your initial question. I can tell you that we have developed protocols for the most commonly performed surgical procedures, the most common chronic diseases. So, we have total hip replacement, knee replacement, spine surgery, bypass surgery, angioplasty, diabetes, CHF, COPD, chronic kidney disease, hypertension. I don't know what percent of patients that is, but we have protocols for all of those. It has to be led by the providers, the docs. And what we started with bypass surgery, and there was sort of a challenge from the CEO to the head of cardiovascular surgery. And they, instead of trying to boil the ocean, they focused on a subset of, say 40 out of 160 or something guidelines, about which they couldn't disagree. They all said, we should do this all the time or never. And once they had made that decision, it didn't happen overnight, but they had to go through reviewing the data. And I've had many years of experience where the experts think they know the data, but they don't. And when they actually review the data, it does influence their viewpoint. So, but they won't do it in their head. You need systems, infrastructure to support it. And it's taken us a long time, and we're still developing these. And it's not perfect, but.
So, Earl, help me understand. So, of the providers who are subject to the guidelines and use of the EHR, how many of them are full-time clinicians, and how many are employed by Geisinger?
So we have 1,100 employed, about 1,100 employed physicians. As we have been acquiring other hospitals, that's changing. And most of the docs in these newly acquired hospitals are not employed. They're independent. So we are learning how to deal with that. We have helped implement over 160 medical homes. About 70% are in practices where the docs are independent, not owned. And it's a different setting. It is definitely easier when the docs are employed, but just because they are employed doesn't mean, they're compliant.
Steph, and then Mary and Dan.
Okay. Hi, Earl. Thanks very much. One of your comments about using data real time to be impactful and to drive behavior, I'm using my words, not yours, but trying to drive behavior in real time. As you know, we are in the process of implementing Epic. Just for the record, we signed our contract with Epic in 1990, believe it or not, but only implemented administratively some of their features and functions until the last 2 or 3 years. But one of the challenges we have, and Patty's already alluded to it, is creating a meaningful data warehouse. We have Cogito, which is Epic's newest data warehouse, has about 5 million patient records in it, about 10 years worth of data, but using it to influence behavior, understanding how to leverage it and use it. And in part, we're still new at it, so it will take us a while. But all we're doing today is creating derivative data sets, providing them to specific investigators who have a unique problem to solve, investigator-led problem to solve, rather than leveraging that, what I consider to be a relatively large repository, to be impactful at the point of care. Any advice as to how you tackled that?
Well, so first of all, we don't have Cogito yet. We are implementing Cogito later this year. So we still have Clarity, which, as you know, is horrible. But I believe an increasing amount of the data that will be relevant will reside outside of rather than inside the medical record. So I have, argued with Judy Faulkner that, she wants to own and control the world, but no matter what she wants, she will never be able inside of Cogito to have over time what's needed, and there's no way that they will keep up with the changes in science to be able to, provide the type of real-time decision support. So what we do right now in this overnight analysis is not real-time, it's overnight. So it's, near real-time, but it's, fast enough. We only do a couple of things real-time. We have one set of data analyses that operates, that advises on management of insulin for diabetics in the hospital. That's real-time. And then we have a Muse scoring system where you hit a threshold and that patient gets moved to the ICU on an automatic, like that. So those are the only two things we do in real time. But with this app approach, we are able to analyze and provide real-time feedback. So in rheumatology, for example, the patient on their way in to see the doc or in advance fills out a structured, questionnaire, validated instrument on their symptoms, and that disease activity score we then display graphically against their meds and provide clinical decision support on use of some of these high-cost, specialty pharma drugs, which, will break the bank if we don't manage them properly. So I think that whether it's real time or close to real time, I think it's very important. I don't know that I don't know enough about Cogito to know, whether doing the analyses inside Cogito is the right way to go. In our case, we extract it and we do the analyses outside of Clarity. We don't do any analyses inside of Clarity.
Hi. Can you hear me? Thanks. I wanted to talk a little bit about your thoughts on the financial reimbursement model and the implications of that on maybe some of the successes that Geisinger and just some of the programs that have been able to shift from volume to value type thing. Because I think to myself, if Johns Hopkins as an institution were suddenly just paid capitated rates, all of the discussions and the laborious anarchy that takes place with regard to access to data capture, what we need to make informed decisions, the discussions would be expedited so quickly our heads would spin. And I think so much of the problem is related to the financial model that is in place. So I'd really love to understand how you've been able to get the outcomes that you have and what financial incentives you've employed within Geisinger to achieve those.
So let me talk about this. And the only thing I disagreed on that Patty said, I'm going to stick by my view about fee-for-service as the devil in this case. I view it as an addiction. It's like fee-for-service crack. And if you are getting X dollars for a particular service and you can reduce the cost of that service, you'll do better with, financially in providing that service. That's obvious. The problem is the number of units of service that we're delivering. And if you start eliminating volume, okay, then revenue goes down. We have been supporting an academic medical center for their self-insured population. They brought us in because they wanted to sort of, get some experience with delivering higher value care. And since they were self-insured, they were paying out of pocket for that care. We came in, started reducing admissions, readmissions, ER visits. The CFO jacked up the unit prices so that the revenue picture would look better to him and somebody else, even though he was paying himself more. So, I believe, and I've seen it for too long, that fee-for-service incents volume. Now, DRGs are a form of fee-for-service. It's staggering to me, baffling, why we don't do a better job at minimizing costs during a DRG payment stay. There was, Atul Gawande talked about the fact that they looked at the surgical mesh that their surgeons were using for hernia repairs, the simplest surgical procedure that there is. And they found that it varied, the cost of the mesh varied from $25 to $1,500 for what their surgeons were doing. And they sat down, met about it, looked at the data, and there was no reason to use anything other than the $25 mesh. Now, why didn't they figure that out a long time ago? Because they didn't have the pressure is the only thing I can think. But I can tell you that under bundled payment now, when you're looking at, bundles where the doctor's, fees are included in the bundle and post-discharge care, you're seeing a lot of change. And we are finding orthopedic surgeons who before swore by they could not do without whatever hip implant they were used to using. And now suddenly it's okay to use a different implant because they're making more money on the different implant.
So in defense of my remark, I do actually, thank you for at least acknowledging the DRG system.
Yeah.
I do want to actually point out, Mary, as you know, we have, that shift has happened in Maryland. For all practical purposes, Maryland hospitals are now capitated. And yet what you suggested would be the response, I would suggest has not yet occurred. And that's because the folks on the ground, to Earl's point, have not had their incentives changed. And that's because we've not changed our organizational model and or our incentives within our organizational model. So I've always been fearful, and I thought reform was in some ways the government saying, we've been giving insurers these buckets of money for years. We're just going to now move the money from the insurer to the delivery system, and the delivery system go at it. And yet, without the tools, the data, the incentives, the organizational models to support that work, we're going to struggle. And we'll see where we end up in Maryland over the next year or two with the new waiver. There's one more question I have right here. Dan.
And it's sort of similar to the questions you guys were just answering. So in that shift, at the level of the individual physician, the employed physician, what percent, if you have a ballpark percent that you recommend be RVU versus other, in other words, what kind of replaces the traditional eat what you kill fee-for-service mentality on the ground at the level of the person that's kind of interfacing with the patient?
We use a 20-80 split. So about 80% is based on RVUs. They have a target, and I don't remember what the percentile is that they're, pegged at. And 20% of their comp is based on factors other than volume, and it varies by specialty and it varies by year, depending on what the system has prioritized. The other thing to organizational, I don't know if this organizational structure or models, but like in primary care, those quality bundle scores influence, I mentioned the bonus payment, everybody in that practice, their bonus depends on the performance on those measures. And when I've talked to the primary care docs, they consistently say, you do not want to be the person who is responsible for that front desk person not getting their bonus.
All right, join me one more time in thanking Earl for a wonderful talk and Patty for leading our discussion.